from the Diabetes Club of Dindigul to all the delegates present here. As a doctor practicing in the diabetes capital, the India, we have to know, each one of us should know the drugs effects, adverse effects clearly. With this vision, here is our 103 scientific program of DCD, a virtual session again. Today we are going to get more insights into one another therapeutic option in the diabetes armamentarium, that is pioglitazone. Here we have our Dr. Pavan Kumar, physician, one of our executive committee member of DCD, to present the welcome address today.
Thank you, madam. Good evening, everyone. I cordially invite our respected speaker, Dr. A.J. Asirvadam, sir, Senior Consultant Diabetologist, Madurai, and other senior diabetologists, senior physicians, and my colleagues for this 103rd Diabetes Club of Dindigul online scientific program on pioglitazone. As everyone knows, pioglitazone, which was earlier banned because of its fatal adverse effects, and again reconsidered into the market. So we are very eager right now to know the mysterious hidden concepts about this pioglitazone being resolved right now. Thank you, sir. Over to Dr. Anita.
Thank you, sir. From the desk of secretary, and I am happy to announce the much awaited e-journal will be released by this month end, August. And last month meeting topic, choosing the gliptins, by Dr. Anantharaman was really wonderful, and he really simplified the options for us in choosing the gliptins. Today we have a wonderful speaker with us, A.J. Asirvadam sir, to resolve the mysteries of pioglitazone, which is the most controversial drug. I welcome our Finance Secretary, Dr. Satish Kumar, to give speaker introduction.
Good evening to everyone. I am Dr. Satish Kumar. Today, the speaker, Dr. Asirvadam sir, truly he doesn't need any introduction to our club. He is just like a mentor and even a member, like a member of our club. He is so much associated with us in our club activities, and with heartful gratitude, we do remember his contribution to the track 2018, which our DCD club was conducted. So sir was a speaker for a specific topic. So as a mark of tradition, I wish to introduce him. Dr. Asirvadam sir graduated from Madurai Medical College. Both MBBS and MD he did in Madurai Medical College. And in 1991, he did his diploma of diabetology from Madras Medical College. And he also done his diploma in diabetes care graduation from University Newcastle, Australia. And he was awarded FRCP Glasgow, Royal College of Physician and Surgeon of Glasgow in 2017. So having this rich academic background, he served the diabetic forum through various means. He was the chairman of RSSDI Tamil Nadu chapter, and he was the president of Madurai Diabetic Club, and he is also a senior consultant diabetologist in Asirvadam Hospital, Madurai. And he presented more than 76 papers till now, and he contributed to more than 14 books academically. And in research also, he was a principal investigator in clinical research. And of late, his Treat India 2, that is teneligliptin effectiveness assessment in type 2 diabetic mellitus in India, is a milestone in his clinical study. And he was awarded the Lifetime Achievement Award by Dr. Mohan's Diabetic Research Foundation, and he was also given the oration of Professor Sam G.P. Moses and Professor Vijay Rangan Memorial Oration Award also presented. And regarding his academic achievements, his recognition as a diabetologist, he has his own social interest also. He runs a Diavention Trust, by which he has conducted more than 308 meetings in more than 100 centers. And this trust is a patient-friendly and non-profitable trust. So he served the society also. So we are very glad to have you with us, sir. And it is our pleasure to have you with us today for this very tactical topic, because many of our fellow physicians and diabetologists and general practitioners like us are mildly, we don't frequently use pioglitazone. So today, after this meeting, I think our focus might change. So we welcome you, sir, and thank you for your presence here, sir. Thank you, sir. Thank you.
Anita, you please mute all the doctors.
I am not able to mute, sir. I will ask the host.
Yeah, please,
Host, please mute all others except the speaker.
Yes, sir. We are very, you are very kind enough to be with us today. So we eagerly await your academic fees, sir. Thank you, sir. We welcome you, sir. Thank you.
Can I have the option of sharing my screen?
So please, sir, you can share. Yes, sir. Visible now. You can make it full screen, sir. Yes, sir.
Good evening, everyone. As far as the Diabetic Club of Dindigul, I am very, very homely. And moment I heard that it is for Dindigul, I wanted to definitely be part of it. I cannot forget you, I can't miss you, and I cannot say no to you. So I'm very much attached to you. Not only the old office bearers who have been my students, so the new office bearers have also really had the a love and affection or of the same trend. So I am not able to refuse anything from you. And it is a joy, pleasure, and the privilege to associate myself with you on this particular occasion. The topic given to me is really a mystery. Pioglitazone is not an ordinary drug. It could be compared with Kamala Hassan, wherein his particular movies are always controversial, though it is very interesting and useful. The other aspect of it is it could be compared with James Bond 007, which was termed or titled as You Only Live Twice. I don't know how many of you have been born and seen this particular movie, one of the very nice movies of James Bond, Sean Connery, and wherein Sean Connery dies and comes alive as in a mission. So also pioglitazone, as you know, died, was banned, and later resurrected and came to being. I would talk to you about this particular molecule, its mystery, and what happened to the mystery now it is solved. I will take you through introduction, the mechanism of action, the unmet needs of any anti-diabetic drug, and how you really plug the unmet needs. There is a bitter side of every molecule, and I will be telling you about the bitter side of this molecule also, and how you really come over with the very evidences, and how do you really achieve a balance between the need, the usefulness, and the bitter side. So to introduce this particular drug, every drug in any specialty has good qualities as well as bad qualities. And the final decision to take up a drug is its risk-benefit ratio, the cost effectiveness, the long-term durability, and ability to counter the pathogenic mechanism. And today I can talk to you about pioglitazone, which has emerged successfully as a drug for the use in diabetes since it fulfills most of them. the mystery on this particular drug has also been proved to be untrue. Now we'll just look at the mechanism of action. This is one drug which is orally absorbed, goes into the systemic circulation, reaches every tissue in the body, particularly the muscle tissue, the fat tissue, and the liver. In these liver tissues, it goes into the cells of these tissue, not only the cytoplasm, but also to the nucleus. This is the blue one, is a nucleus, and sits on a receptor called PPAR receptor. Then it combines with a receptor called RXR, retinoid receptor. And the moment this combination happens, it is able to synthesize the mRNA, which is responsible for the protein molecule or the glucotransporters 2. So once the production of this glucotransporters 2 is in abundance, it goes from the cytoplasm to the exterior, picks up a glucose molecule and turns back. This is how the glucotransporter acts as a vehicle for glucose entry with a limited amount of insulin. So with less amount of insulin, more amount of glucose uptake at the periphery. This is what happens in the muscle, converting it into energy or little bit of storage as muscle glycogen, which is useful only for the muscle. Then it also is taken up by the fat cell, where it is converted into a fat depot and stored, and also acts on the liver and also stores it as a glycogen, as well as acts in a very important way for the NASH. What are the unmet needs? So probably you could remember one old movie called Manal Kair by Segar, S.V. Segar, in which a young man tries to plan a marriage and tries to look for a bride. And he gives a long requirement. She should be tall, she should be fair, should have a long hair, should be very attractive, she should be able to dance, should be able to sing, and should be able to be very rich. So this is something, the expectation of a bridegroom or probably a young lad. So also the expectation of a diabetologist, as far as the drug is concerned, is the drug should be very efficacious in reducing blood sugar, and it should not be short acting. It should be quite long acting per day, as well as should be useful for a very long period of 4 years and 5 years. It should also reduce the mortality and morbidity. It should also preserve the beta cell. It should reduce insulin resistance and should not cause hypoglycemia. It should also prevent diabetic complication. It should also be cheap and easily available. And few more are the safety at all angles. It should be a very safe drug, and it should also be weight neutral. As for today, you don't have a single drug which fulfills all these needs. But does pioglitazone come anywhere closer to this particular ideal drug? Yes, it comes to almost closer to an ideal drug. Look at the efficacy of reducing blood sugar. The hemoglobin A1C reduction with monotherapy of pioglitazone is 1.6, and a fasting reduction of around 65 milligrams. Just compare it with other drugs, it may not even reach this much, but in general, OHAs range from 0.8 to 1.2% of hemoglobin A1C reduction. So this tells you it is an efficacious drug. What about the durability? Comparing glimepiride, which is now the gold standard for comparison, look at this particular blue line. It reduces suddenly, but the durability is much less. It goes up, and almost in 72 weeks, it comes back to the original level. Whereas you might remember the ADOPT study wherein rosiglitazone also had showed a similar durability, and this is again a pioglitazone study wherein it gets reduced and maintains for a very long period. Next is the least square mean change from baseline about the HDL. Look at glimepiride, this is not effective or probably very less reduction of hemoglobin of HDL, which is a good cholesterol. Whereas with pioglitazone, the HDL elevation is very good. So the durability has been certified. What about the mortality? Even when you compare metformin, it is able to give you a significant lower risk of all-cause mortality as well as lower cause of all-cause mortality when compared with metformin or when compared with rosiglitazone. How is it able to preserve beta cell? It is acting in the indirect way as well as in the direct way. With the direct action on PPA or gamma, it is able to replenish the cell by increasing the beta cell mass, improving the beta cell proliferation, reducing apoptosis, and positive influence on morphology of islets, as well as reducing the need of insulin secretion by reducing its requirement, by improving the insulin sensitivity at the periphery, thereby achieving more glucose uptake with less insulin and increasing insulin signaling, which improves the insulin synthesis of the beta cell. Not only synthesis, also the secretion and improvement of insulin secretion pattern and reduces proinsulin. Looking at the indirect effects, it also reduces lipotoxicity, which is a very important. What is this lipotoxicity? When fat mass dwindles down, when lipolysis occurs, free fatty acids roam around the circulation. This causes insulin resistance at the periphery. Whereas pioglitazone, acting at the adipose tissue, produces lipogenesis and not lipolysis. It inhibits lipolysis, less of free fatty acid, so better insulin sensitivity at the periphery. It also reduces glucose by disposing glucose into the cell, adipose tissue and liver cell, thereby improving the beta cell function. It also reduces TNF alpha, a villain, and increases adiponectin, a hero. By all these measures, it improves beta cell preservation. What about insulin resistance? The effect of insulin on the visceral fat metabolic activity in impaired glucose tolerance or type 2 diabetes produces a decreased visceral fat volume and increase its metabolic activity in IGT or type 2 diabetes. Beneficial effects of pioglitazone on visceral fat may be independent of glucose lowering effect. So pioglitazone slows progression of atherosclerosis in pre-diabetes, which is also independent of changes in the cardiovascular factor. It slowed progression of the carotid intimal media thickening, independent of hyperglycemia control, insulin resistance, dyslipidemia, and inflammation in pre-diabetes. It has also got a direct vascular benefit. Look at this entity. Hypoglycemia, when compared with glyburide, you have some very low or almost negligible, related almost same as metformin. Other studies have also shown a reduction. How does it prevent the diabetic complication? It corrects dyslipidemia, improves the endothelial function, correcting the endothelial dysfunction, atherosclerosis, which is a very important pathogenic mechanism for myocardial infarction, stroke, and peripheral vascular disease. Also reduces the carotid media thickness, reduces myocardial infarction, stroke, and even nephropathy. Coming to each one of them, dyslipidemia, it reduces triglyceride, it increases total cholesterol a bit, and the HDL increase is tremendous. So the ratio between LDL and HDL is on the favorable side. Next is about the endothelial dysfunction. The flow-mediated dilatation with pioglitazone from the baseline value to a post 4-month study showed a very good increase. So flow-mediated vasodilatation is you check the endothelial function by just checking up the BP and also comparing the diameter of the brachial artery, which is also given as a very important index of endothelial function, which it improves. Coming to atherosclerosis, it acts at various levels, improves lipid profile, reduces blood pressure, reduces microalbuminuria, improves endothelial function as I alluded to, reduces inflammatory markers like CRP, reduces PAI1, and also has other potential anti-atherogenic properties. So once the PPR gets activated, you have the direct effect and indirect effect. The indirect effect occurs at the fat, liver, and skeletal muscle, by reducing FFA, reducing glucose, improving insulin sensitivity, reducing triglyceride, increasing HDL, and decreasing atherogenic LDL. Very important, atherogenic LDL. Thereby inhibiting atherosclerosis. So also by the direct vascular and inflammatory cells, reduces cytokines, chemokines, increases cholesterol efflux, and it decreases adhesion molecule. The adhesion molecule in the endothelium is just jutting out like an antenna, wherein the macrophages, which are loaded with fat, go and get attached, then go into the vascular layers in between the endothelium and the tunica intima media. So this is how the PPR activation is able to take it through atherosclerosis reduction. This is another wonderful study, the intravascular endoscopy, which showed an atheromatous plaque, and you are able to identify the atheroma load or atheroma volume. And with this, you can calculate the pre-exposure and the post-exposure, which shows there is a, see, this is the atheroma, and you have the intravascular ultrasound, which is called the periscope study, in which it has reduced the atheromatous volume, which you see the glimepiride it is increasing, whereas in pioglitazone it is decreasing. Such a wonderful drug. So the change of percentage is significant. And then second is about is carotid intimal medial thickness. You see here the change in posterior wall medial CIMT due to glimepiride causes little increase, whereas pioglitazone causes a reduction and almost at least maintains the same. Coming to myocardial infarction, there is a good reduction between the placebo and the pioglitazone arm of therapy, which is quite significant. And its time to fatal and non-fatal MI, including silent MI, is definitely much lesser with pioglitazone. The period is longer. The preliminary data support reduction in myocardial infarction with PPR gamma activation, which shows favor when compared to insulin, it favors oral therapy. And you see here sulfonylurea, metformin combination, and thiazolidine much better, far away from the line of the median. This is just to show you the combined endpoint of cardiovascular mortality, non-fatal myocardial infarction, and stroke, which is much less when compared to comparing pioglitazone. These are all non-significant, and in other entities like IMPA, LIRA, with leader and sustain, it is almost positively correlated. The proactive study showed the time to fatal and non-fatal stroke is prolonged, and when compared to a previous stroke patient, there is obvious reduction in the second episode. So also nephropathy. This is a recent study wherein it showed reduction in the urinary albumin creatinine ratio by treatment with pioglitazone in type 2. Look at when compared with metformin and pioglitazone, metformin is only this much, whereas here you have a very significant reduction of almost 20. And so also when compared with sulfonylurea metformin, these are increasing when compared to metformin pioglitazone combination. Coming to the cost and availability, it costs less than 44.5 rupees, and it's available in any medical shop for that matter, and it's even now it is still more cheaper, and it is marketed and manufactured by many people. So availability is not at all a problem. Coming to the bitter side of this molecule, bladder cancer, volume overload leading on to edema and cardiac failure, weight gain and fracture are the problems with this molecule. Now we'll look at these complications and see how it fares. Only 8 cases of bladder cancer in pioglitazone users have been found in India. And also, when you compare with other medication, sensitizers, secretagogues, thiazolidine are 0.68. The hazard ratio is only 0.68 and nothing more than 1. And this is another study which says pioglitazone plays a beneficial role in the treatment of diabetes. And US FDA and other health agencies have reviewed all available data and concluded pioglitazone has a positive benefit, the risk ratio. This is again thiazolidine and cancer, results of a meta-analysis of randomized clinical trial, which also shows that from the median, everything favors thiazolidine in all these studies. So that also gives you a significant reduction in breast cancer. So maybe this is an added feather to the cap of pioglitazone. 3 recent large studies do not show any evidence of association between the use of pioglitazone and risk of bladder cancer. So these are the 3 studies: BMJ 2016, JAMA 2015, and Diabetologia 2015. So that also reassures our usage for these patients. And this is another study, pioglitazone use and risk of bladder cancer, a retrospective cohort study using data sets from 4 European Union countries. This also showed that type 2 diabetes who initiated pioglitazone matched with other patients with type 2 diabetes in the same country exposed to the diabetes drug treatment other than pioglitazone. So it is in no way inferior or risky when compared to other anti-diabetic drugs. This is also the data set from Sweden, Finland, UK, and Netherlands. Meta-analysis from all the random things showed a betterment when compared to the other entities. Coming to volume overload edema and CCF, yes, it may cause or exacerbate congestive heart failure in some patients. So it is not recommended in patients with symptomatic heart failure and is also contraindicated in patients with established NYHA class 3 or 4. And also, pioglitazone could be avoided in a patient whom you suspect that might go in for heart failure. The combination use of pioglitazone with insulin therapy may also increase the water logging and result in congestive heart failure. So what about the weight gain? Yes, there is a weight gain with pioglitazone due to 2 reasons. One is with little bit of water volume overload as well as increased fat accumulation. So the glycated hemoglobin reduction for the 3 treatment group showed that with 7.5 milligrams, with the hemoglobin A1C reduction is adequate. At the same time, the weight gain is almost very minimal. So this should be considered for the use of low dose of pioglitazone, and with that amount of lower volume, the lower dose of hemoglobin A, lower dose of pioglitazone does not produce much weight reduction. This is a very important slide to show you that the fat accumulation is not in the visceral fat. It is in the subcutaneous fat. So you just see here the subcutaneous fat area is 144.3, which increases to 204.4, which is here, outside the muscle, abdominal wall muscle. Whereas, if you take up the visceral fat area from 140 square centimeter is reduced to 105.1 square centimeter. So this tells you the metabolically important or drawback fat is reduced, whereas it is differentiated into a subcutaneous fat which is metabolically not active, metabolically not dangerous. So this fat accumulation might give some weight increase, but does not produce a weight increase in the visceral fat, leading out to metabolic complication. And sometimes we find a lot of lean diabetics in Indian subcontinent, wherein this drug could be much more useful than pioglitazone as an insulin sensitizer. Now, how do you strive a balance between these two? Pioglitazone should not be considered in patients with current or a history of bladder cancer or those with uninvestigated hematuria. I always say that an SGLT2 is a wonderful drug, but if you're going to give it in a urinary tract infection patient who is not following an hygiene, it may end up with problem. If you're going to give a DPP-4 inhibitor, sometimes it might produce a cardiac failure. Otherwise, it's a very wonderful drug. Sulfonylurea, still the sheet anchor of anti-diabetic therapy, might produce hypoglycemia. Insulin, the best drug on earth for diabetes, also has some drawback of increased hypoglycemia. So, if you use these drugs in the ideal population or an individualized indication, it will be quite okay. It is better to avoid in the cardiac failure or in patients whom you suspect might end up with heart failure, to be avoided in obese patients and elderly women in the fear of fractures, and glycemic and non-glycemic effects definitely deserve its prescription, and lower dose of 7.5 would be a good balance for this molecule. And you have protection of multiple organs, reduction of secondary stroke by 47%, reduction of carotid artery intimal thickening in a significant manner, reinfarction by 28% reduction, acute coronary syndrome by 37%, as well as a regression of atherosclerosis by periscope study, and also reduction of MI, stroke, death in patients with CKD, reduction in microalbuminuria, and 51% reduction on patients on hemodialysis. And one more indication is the fatty liver, where the introduction of inflammation and necrosis in NASH is reduced by about 50%. So all these things really requires consideration in light of the drawbacks of this particular molecule. So the pioglitazone benefit risk remains positive. The combination of mechanism of action, efficacy, durability, and low incidence of hypoglycemia distinguish pioglitazone from other currently available antidiabetic medication. It is the only antidiabetic drug with cardiovascular safety documented by a prospective outcome study. Risks are well characterized in more than 20 million patient years of experience in the past 10 years globally. The very small risk of fracture should be balanced by the benefits of pioglitazone in the context of overall morbidity of patients with type 2 diabetes. Pioglitazone continues to be an important therapeutic option for the successful management of patients with type 2 diabetes. So, dear friends, to conclude, this molecule plugs the unmet needs to a major extent, though not to the full extent. The bladder cancer scare is resolved. No more to worry about it. The fracture is only small bones and not very common. And try to avoid in a postmenopausal woman who is likely to develop fracture on her own. Future risk should probably tailor this molecule to avoid the drawbacks and offer a trouble-free molecule. Till then, this molecule can be safely given, and care should be taken to identify the ideal patient for this drug and use judicially. So with that, I end up my presentation and thank Dindigul Diabetes Club for giving me this nice opportunity, a real good opportunity to be with you, to really see all your faces. That really gives me a lot of happiness, and to share something about a very controversial drug, pioglitazone, which I've been using before and also after its black box warning and the particular period at which it was really taken off from the market. So thank you very much.
So one small question,
That
sir.
was really a,
Madam, yeah, yes.
yes, that was really a wonderful session, sir. The mysteries are really resolved, and we are now clear when and where to use pioglitazone and in what dosage. And now the floor is open for the discussion. Thank you, sir.
So a small question, sir. Sir, it was a wonderful talk, sir. You made so many points very clear, sir. Sir, actually, a patient who has got high insulin resistance tends to be obese also. For that patient, sir, pioglitazone will be a very good molecule, isn't it, sir? It can reduce his insulin resistance, and also probably for the fear of putting on weight, you may avoid it. But suppose you combine it with an SGLT inhibitor, will that combination be wonderful, sir?
Yeah, you can definitely do that. Because today we have got drugs, and particularly combination with SGLT2 will also reduce the volume overload.
Yes,
so
sir.
edema also will be less, cardiac failure also will be prevented. So that combination also will be quite useful. You could also combine metformin with pioglitazone so that the insulin sensitivity action also will be better, another weight neutral drug, and thereby you could reduce the dose of pioglitazone to 7.5.
Yes, sir.
A very good combination.
But a patient who is obese and who is high, has got high insulin resistance, this is a very good drug to start with, initiate, because it acts at the root
Very
cause.
frank with you, this acts very well if the person is going to be very obese.
Yes, sir. That's what I. If a BMI is more than 40, this will be ideal drug because it reduces the insulin
Insulin
drastically.
resistance more, and when it compares that insulin resistance, you get a lot of benefit. But the drawback is they will put on more weight.
That's what. That's the query. How to balance that? I don't know. Probably. Yes, sir.
So
And,
probably you will have to probably add a GLT2 or even with a GLP-1 receptor agonist and also a lower dose of 5-glutazone.
and will you?
That's lifestyle modification.
Yes, that's true. And will diuretics be effective to relieve the edema caused by pyruvate, sir? Your diuretics. Will diuretics be effective in relieving the edema caused by pyruvate? You should diuretic.
Yeah, it could be used, but having known the cause of edema, if it is going to be very significant, it is better to stop the drug.
Actually, this drug starts acting only after 3 to 4 weeks only. They start acting.
It's not immediate. It doesn't take up action immediately.
And even when you stop the drug, it will take another month for the weight to gradually reduce, isn't it, sir? Gradually, the weight.
Good evening. Hello.
Yes, Dr.
Welcome.
Good evening. Good evening.
Well, why should not be given along with insulin?
Sorry? Why?
Why should not?
Insulin. He is asking combination of 5-glutazone with the insulin. Why
Because
is not advised? Yeah.
insulin has increased water logging effect because insulin acts at the collecting ducts, just like an antidiuretic hormone, and imbibes water. So that is why insulin-induced edema itself is a separate topic and one of the drawbacks of insulin. So when that is happening, and you also add one more entity like pioglitazone, the edema will be much more dominant. So that is why you should be a little more careful because it could precipitate a cardiac failure and obvious edema legs.
That's a beautiful presentation, as usual. One of my doubts is, what about the percentage of macular edema with the use of pioglitazone?
Yes, macular edema is again another drawback, but the percentage is very less. So I have not stopped because every one of my patient undergoes fundus screening, and also in case of if there is any problem, they immediately I have referred to an ophthalmologist for tackling that problem. So in my experience, I have not seen much of macular edema due to pioglitazone. So at the most, out of 100 patients, 1 or 2.
Okay,
and that too, we cannot, this is not a double-blind crossover trial or double-blind RCT, no? So you can't blame only the drug for macular edema. The macular edema may be due to the diabetes event. So even in that situation, you can't say it is because of pioglitazone.
Yeah. What about the use of pioglitazone in the fatty liver in a non-diabetic patient? The non-diabetic patient, will you advise pioglitazone for the management of fatty liver?
Management of?
Fatty liver.
Fatty liver, that is one of the indications, but it is not recommended in a non-diabetic individual because fatty liver has no specific drugs as on date. A lot of drugs are recommended. Vitamin E, particularly in diabetic in NASH. Number 2, saraglitazar, which is also a brother of pioglitazone, because the gamma action is little less, alpha action is little more. So that is another important drug. The third drug is SGLT2 inhibitor, which is up in the market, is also going to be used as a drug for NASH. And beyond this, you have metformin, which is an old molecule, which could also be useful in reducing insulin resistance at the liver, reducing NASH. But so far, you can't use these drugs without any other diabetic indication.
Physical activity and diet modification. We have to improve the physical activity.
Yeah, that is ultimate.
Yeah.
Without physical activity, there is no treatment modality. Patient coming out of the chamber of a diabetologist should never ever skip or stop exercise.
Exactly.
If he skips or stops exercise, that means he is inviting trouble and causing a bad name to the physician.
So one more doubt.
How much weight gain you have seen so far, sir? Like What was
4
the
kilos, 5
maximum?
kilos, up to that.
What dosage, sir?
I have never gone beyond 7.5. Maybe 1 or 2 patients who are lean, I would have put them on 50. I have never tried 30. I have never gone in for 45. So it's only 7.5 only.
Have you ever met any
And
fractures?
I started using rosiglitazone also at a dose of 2 milligrams and found to be very useful. But unfortunately, rosiglitazone died. It was not able to come up like 5-glitazone. So that's a sad story. Probably we'll discuss it somewhere there, another occasion. But 5-glitazone with 7.5 has not been a troublesome dose.
How about fracture incidents, sir?
Again, very few, very few.
Sir, shall I try
Maybe you could avoid it in
7.5,
a
sir?
patient who is
Postmenopausal?
osteoporotic and particularly women after postmenopausal age.
Sir,
How
shall we use?
how,
Okay, madam. Can I?
Yeah, Jaydeep.
this is the last question, sir. How about pioglitazone in PCOD, sir?
Yes, a very good indication. But the problem is that if you are going to give it initially and the patient conceives, then the problem starts. But that could be given for a very short while, but still they don't have a definite evidence. So whereas if the patient is maintained on metformin for PCOS and the patient conceives, you can perfectly officially continue metformin during pregnancy.
I am talking about the unmarried lean girls who comes with the lean
Yes.
segment of PCOD.
Yes, but beware weight gain. The patients are quite lean, you could use it. Whereas if the patient is obese, might increase the dose of metformin.
Sir, as more and more young diabetics are diagnosed nowadays, shall we use safely pioglitazone as a second-line drug after metformin?
Yes, but what had happened, this drug has definitely been very unlucky to come up to the real expectation or to come to the limelight of physicians and diabetologists. What had happened is this molecule primarily started its origin from Japan. So there was always a problem of resistance at the US level. And it was costing $1 per tablet. Whereas here it was 4 rupees, 2 rupees. So we started using this much more than the US. So it has not come into the recommendation unless in the small sector where hypoglycemia free treatment is recommended. So if you are following any of the recommendation, the first drug of choice will be metformin. The second drug of choice will be, if IHD, you choose GLP-1 receptor agonist or SGLT2. If CKD, SGLT2 or a GLP-1. If you are wanting something to be for hypoglycemia free, then probably you can use this as a second add-on apart from GLP-1, SGLT2, alpha glucosidase inhibitor and pioglitazone. Even alpha glucosidase inhibitor is not entertained by any of the guidelines. But as you and me really see that alpha glucosidase inhibitor does not produce hypoglycemia, definitely reduces the postprandial hypoglycemia, so it could always be used. So these are all things which are not in the official recommendations, but still they are not in the kit list. So probably you could use it with some amount of prudence.
Good evening, sir. It was a nice talk, sir.
Thank you, Satish.
Leaving alone the guidelines, sir.
Ah.
In practice, what is the percentage of patients you starting on pioglitazone? Because the cost advantage and safety advantage of other group of anti-diabetic oral drugs are much better than this drug. So in your practice, what is the percentage of patients likely you use this molecule, sir?
My usage would be, if a person is very lean and I feel that he has to have some insulin sensitizer, I use that. The second indication is that as a third add-on, particularly when the patient's cost factor is important or you don't have any other option. You combine the insulinotropic drug and insulin sensitizer like metformin, and still you are not able to get a good combination, good control, or a patient is lean with some DPP-4 inhibitor and some other drug, metformin. At that point of time, I remove metformin, put them on with pioglitazone. The total number of patients I would have used in 100 for 100 patients, will be around 10 to 12. So not in every patient. So in every patient, you can't give any drug. So metformin may be used in about 80% of drug patients, DPP-4 in 80 to 90% of patients, SGLT2 around 30%, alpha glucosidase in about 20 to 30%, and this is in about 15%. So insulin, at least in the later diabetic or longer duration of diabetes, almost 50%. To start with, it will be only 10% or less.
Beautiful, sir. Beautiful.
Good evening, sir.
Yes?
Jayati?
I'm not able to hear you.
Sir, good evening, sir.
Yes? Good evening. Tell me, doctor, how are you? Dr.
Fine,
Jayanti,
sir.
tell me.
Yeah. Fine, sir. Your talk is very nice, sir. Thank you for your talk, sir.
Thank you. It was really, I'm not exaggerating or, saying anything untrue. Dindigul has been very close to my heart. And Jayanti, every one of you, it's almost like a family, I would rather say. I would not say anything else other than that. It was a professional family at Dindigul. So thank you for the opportunity. I really enjoyed seeing all of you, talking to you, and also sharing the topic. So, any other questions? And when I really started accepting it, Dr. Anita was expecting me to come out to the Dindigul. So I said, I would very much like to come and meet you all. But unfortunately, due to Corona, I may not be able to do it this time. And probably I will at least attend your meeting, even if not a speaker. Moment situations are better.
Okay.
So thank you. Wish you all
Thank you, sir.
a
Very nice.
success. The new team. I specifically wish each one of you to do as much as possible to the community as well as to the fraternity, which is going to be well rewarded, if not today, later. Thank you. Bye.
Thank you, sir.
Thank you, sir.
Thanks. Very nice.
Definitely follow
Great.
your words.
Thank you, sir.
I welcome our physician, Dr. Sudarshan, to deliver the thank you address.
Good evening, everyone. That was a very nice presentation, sir. It's really an eye-opener for all, because there is a resistance in using pioglitazone. We have hardly seen very few practitioners using pioglitazone, even though it's a wonderful drug. Thank you once again, sir, and thank you for the sponsors. And I thank you all the members of the DCD team for giving me the opportunity. Thank you.
Once again, thanks the sponsor, Sun Pharma, Azura Division. And probably if the COVID spares us without the third wave, we will have the direct session for the next meeting in September. With the word, thanks everyone. Thank you.
Bye.
Thank you all. Good night. Thank you, boss. Thank you.
Thanks everyone.